All right, so hello, I'm Mike Hoefer. I am an addiction psychiatrist here at the VA, and I run the opiate treatment program. And today we're going to be talking about clinical drug testing and specifically how to interpret clinical drug tests. So we're going to start off with some cases. The first case is a 24-year-old male who's brought in by ambulance, obtunded, has pinpoint pupils, has a respiratory rate of 6. The urine drug screen is negative for opiates, oxycodone, and methadone, and is given naloxone 0.2 milligrams IV, and within seconds is very alert and very not happy with you. What do you guys think is going on in this situation?
Fentanyl.
Okay, excellent. And why fentanyl?
Because it doesn't show up on urine drug screens usually.
Gotcha, yeah. So fentanyl is a fully synthetic opioid and doesn't show up on normal urine drug screens, so you have to test for it specifically. Now, if you give somebody Narcan, how long does that typically last?
15 minutes.
Yeah, anywhere, depending on what they took and how long, but it can be 15 minutes, it can be 30 minutes, it can be even up to like 45 minutes, hour. But it is somewhat short acting, so it can go away. And so, oh, and by the way, these are all kind of real cases. So in this case, let's say you give him Narcan, and then after an hour he stops breathing again, and then you give him another one, and you do that maybe 2 or 3 times. What do you think could be going on? What are some options that could be going on there?
Maybe he has a patch on.
Excellent. Yes. So cutting right to the chase. So yeah. So one thing it could be he just took a very large amount of very long-acting opioids, and they're sticking around while the Narcan is wearing off. The other is that fentanyl is available in patches, and people put those patches in all sorts of interesting places, and so you got to make sure that you kind of do a body exam and get those off, or people can continue to overdose. Excellent. Okay. Second case is a 45-year-old female who's housed, married, employed, has a history of alcohol use disorders, prescribed clonazepam, 0.5 milligrams twice daily by a medical practice provider, has had multiple recent urine drug screens negative for benzodiazepines, and has been told by the primary care doctor, you know, your urine tests are negative for benzodiazepines. I think you're not taking these medications and diverting them. What do you guys think about that decision?
Clonazepam doesn't usually show up in a urine drug screen. It's metabolized differently, so she might not be diverting.
Excellent. Yes. So clonazepam does not interact very well with the benzodiazepine immunoassay, because the immunoassay was actually developed, 20, 30 years ago to react specifically with Librium and diazepam and other older benzodiazepines. So it doesn't really test positive. At least at our VA, you don't really see it to test positive consistently until you get above 2 milligrams per day of clonazepam. And that can actually be useful to know if you're doing tapers with people on clonazepam, you can actually kind of check in and see, oh, did they actually make it below the taper I was giving? Because you will then see their clonazepam their benzo screen start to go negative. Okay. All right. Here's another case that I've seen here at the VA. So a 65-year-old male with severe opioid use disorder with chronic pain who's on methadone, who needs a hip replacement and is an injection heroin user, and is told by orthopedics that he needs 6 months of no substance use before can get this hip replacement. He's doing very well in treatment. The screens have been negative for 4 months, and then the test came back positive for methadone and opiates. He denies taking heroin, but was told by the surgeons at the time, you need to go back to day 0 and get another 6 months before we give you a hip replacement. What could be going on, and how could you potentially verify the patient's story?
You do like a send out for confirmatory work.
Yes, so you could send out like a confirmation test, and if it was heroin, what would come back? What would come back on the confirmation test?
Something. There's like a 6 in the beginning.
Something. Okay. Great. So it sounds like you guys have they heard of something with the, yeah, so there's something called 6-monoacetylmorphine, which is something, intermediary metabolite, and if you find that in urine samples, that is pathognomonic for heroin use. So if that's not present, do you guys actually, does anybody know what heroin actually is, like chemically or structurally? No. So heroin is basically diacetylmorphine, so it's 2 morphine molecules with like a functional bridge connecting them. And so when you get that into the body, and those that connection actually makes it more lipophilic, so it gets into the brain quicker, which means it gets you higher and makes you feel better compared to morphine. Once it gets in the brain, it gets cleaved, and in that metabolism, there's a small period of time where there's monoacetylmorphine, and that's only really present for about 4 to 6 hours. So if somebody uses and you test them, soon afterwards, you may detect that, and then that can be suggestive of heroin use. If you don't get them within that window, you won't see it, and then basically you won't be able to tell whether it was heroin use or morphine use because it'll just show up as morphine. So that test is only useful if it's positive. Negative doesn't necessarily tell you anything. Does that make sense to people? Yeah.
Negative within 6 hours would be.
Potentially, yeah. Yeah,
Potentially.
so if you knew for sure they used and then you tested within the timeline, and it was negative, then yes, could potentially, yeah. Okay, great. This is one that we see. So another young person, opioid use disorder, Suboxone maintenance, recent drug screen positive buprenorphine opiates, denies using non-medical opiates, reports going to a Russian bakery recently, which we have all over the city. Mostly the Richmond though. What do you think's going on here?
She had some poppy seed cake.
Yeah. And so, over time they've adjusted the limits, the cutoff limits on these tests to try to avoid false positives for all sorts of reasons, and one of those is poppy seeds. But it still is possible to have a poppy seed positive test, and especially if anybody have seen those poppy seed rolls from like the Russian bakeries, they have like thousands of poppy seeds in them. They're like really potent. So that can happen. And so how does it play out clinically? Basically, people say, oh, I took, I had a poppy seed bagel and that's why my test is positive. And then we say, okay, well, please stop eating poppy seeds because we have to go by the tests and it obscures our ability to kind of monitor things. And it's not hard for most people to avoid poppy seeds in the world. So, yeah.
And how long does it take to wash out?
Similar to, the levels are lower, so it takes a little while to wash out, but it's usually within a few days, but similar to other opiates. Yeah. Okay. Here's a 56-year-old male, alcohol use disorder, history of 5 DUIs, court mandated to our intensive outpatient program. Shows up every Monday, Wednesday, Friday, breathalyzing negative in the morning, denies any drinking, but there's concerns from our veteran justice outreach that he is not being truthful, essentially going to IOP and then drinking as soon as leaving, and that's their concerns for that for him. How may you try to assess if this person is continuing to drinking or not? Yeah, so so that's a test for alcohol. Can you tell me things about that test?
I think it shows over a period of 3 days the metabolites and alcohol.
Okay.
And so you can see if they've had anything in the past 3 days. So as opposed to breathalyzing negative in the morning,
Sure.
which is just like a couple hours.
Yeah. Has anybody in here used CDT tests before? Yeah. Can you tell me kind of what the sample was and how useful it was?
So it stands for carbohydrate deficiency transferrin.
Mm-hmm.
And essentially, I thought it looked at actually a longer period of time, like heavy alcohol use over a couple of weeks.
Mm-hmm.
And the time that we used it most frequently was patients that were in the hospital for some sort of procedure and were attended and having symptoms that were sort of delirium that were inexplicable. Nobody had properly assessed what their alcohol use was, and they ended up in the ICU, and we'd look at CDT to find out where they actually had the alcohol users. Could they be going through delirium tremens or other symptoms is what's going on.
Yeah. And what were you using, urine or blood, or what was the sample you were using?
It was a blood sample.
Blood sample. Yeah. Excellent. Yeah. So that's one option. The option that we use here at the VA, just based upon what we have available through the lab, is ethyl glucuronide ethyl sulfide testing. I don't know if anybody has used those before, but those are basically minor metabolic pathways in alcohol metabolism, and they will detect alcohol use up to about 96 hours or so, and so they can give you a longer window of detection, and can be useful in these situations or in general for monitoring.
Is the CDT longer?
It's a longer window of detection, yeah. Yeah. Okay, so those are the cases, and hopefully through some of those cases it kind of shows why it's important that we have some understanding of these tests. And the things that are, I think, very interesting when I got interested in this and started reading about it is there's actually a lot of, there's some data in the research literature showing a lot of concerns that physicians and other prescribers, we order these tests all the time, but we actually are not very good at interpreting them. And they've actually done some research showing that only 20% of family practice physicians attending level are able to answer, half or better of basic questions of drug testing. Same thing with 27% internal medicine residents. I imagine it would be just as bad, if not worse, for psychiatrists. So this is not picking on family practice or internal medicine. We really don't get training in this. We order these tests all the time, and if you don't know how to interpret them, you could really negatively affect patients' care. And we'll talk about ways that I've seen that happen. The one with internal medicine residents was actually an interesting study because beforehand they actually asked them all, how confident are you in doing these? And they actually found a difference by gender in correlations. So the more confident the males were, the worse they were at interpreting these, and different for the females. They were more accurate. So that's another thing, is a lot of us as doctors are, we're very confident, but we actually don't always know what we're doing. So what are some things I've seen so one of the things I do at the VA is I run the opiate treatment program, so I look at hundreds of these tests every year, but I also have training as a medical review officer, so I also get calls from kind of all over the hospital to help interpret drug tests and figure out what's going on. And so things that I've seen is patients that have been told you're selling your drugs and cut off even when they're selling your medications, even when they are not. It's just the test is not being interpreted correctly. I've seen people have their surgeries and other medical procedures canceled incorrectly. And also one thing we still struggle with is people getting kicked out of housing and residential drug treatment for misinterpretation of drug tests. So it has real consequences for people. So positive effects of drug tests. I think overall drug testing can get a negative reputation because I think it is and sometimes used kind of in a coercive manner or to really catch people. But things that it's incredibly helpful for. So patients in my clinic more often than not actually come to me and ask me to test them more often to support them. They actually find it helps a lot with craving and keeping them kind of in a structured setting. I think also having that information also really helps with kind of just making sure you're having authentic conversations with patients about what's really going on with their health, and people are sometimes hesitant to disclose substance use for all sorts of stigma and other reasons. But if you have this information, you can actually really talk about what's going on as opposed to what's not actually going on. Yes.
In the private world, it's often important to test more often than you need to.
Mm-hmm.
If they're in a custody battle or there's an ongoing divorce, and it isn't just proving the gotcha game, but it's also proving some stability and reliability that you often need in these disputes.
That's a great point. And we actually say that to patients too here sometimes, is when they get concerned about stigma for being in my clinic and not getting certain treatments or not being able to get surgeries. We also say, look, when you're doing well, they ask is test me more often, and that will that demonstrates to everybody in the medical center that it's not because of the X or whatever drug, it's because I need help for other things. We also do it to identify adverse medication reactions. We also do it to monitor adherence and identify if people are not taking their medications and diverting them. Okay, so this is an interesting study. So this is a study by Quest, which is the biggest lab in the US, looking at about 500,000 urine drug tests. And what they basically did was they talked to a bunch of doctors ahead of time and said, hey, your patient, you're their primary provider. we're going to test them, and you tell us ahead of time what you think is going to be in their urine drug tests. And what they found is about only 40% of the time did providers know kind of what was going to be in people's drug tests. So that was interesting. And another thing they had from this study is that this is kind of the breakdown of what they saw. And I think this isn't surprising to anybody based upon what we see as far as substance use. There's another interesting study that I'll kind of walk you through the slide, but it's basically, it's this idea that if you know the rate of substance use in a population, you can use probability theory to determine, like, if you go to the 100% line, that means, let's say you have 100 people and you test them all once over the course of a year, so they each get randomly tested once. If that person tests positive for a substance, 80% of the time that person is using that substance daily, 15% of the time they're using that substance monthly, and only 1.8% of the time are they using it once a year. And this is helpful to have conversations with patients sometimes when we, especially in primary care and other places where they get tested once a year and they test positive for whatever, often the conversation can be, I don't know how you did it, doc. You caught me the one time this year I used something like yesterday, right? And this type of information can give you more useful in kind of figuring out how often people are using when they test positive, depending on how often you're testing. So that's that. And the other thing is there's a number of different areas that have shown kind of research in how drug testing is helpful. So this is issues with Department of Transportation in the late 80s. So we've seen a dramatic increase in kind of substance use, especially peaking in the 70s and 80s in the US. And during that time, they saw a huge increase in car accidents, work fatalities, other injuries, things like that. And so they instituted, at least for what they call these safety-sensitive positions, that's like bus drivers, airline pilots, things like that, mandatory drug testing. And what they found during that was a significant decrease not only in drug use, but also in all these kind of negative outcomes. So this is one area that people look at research to show that drug testing can be helpful. Other areas that I'm sure we're all familiar with are contingency management, which is the number one largest effect size treatment for stimulants. And a big part of that is really just pairing drug testing with positive reinforcement. And also the other thing I think we talked about a few weeks ago was the physician studies which have shown over 5 years of monitoring and treatment, up to 85, 90% recovery from substance use. And a big part of those treatments is basically drug testing and having, in that sense, a kind of a punishment or a negative reinforcer if you are not compliant. Yeah. Okay, so drug testing. So just one thing, just want to make sure everybody knows that really thinking about drug testing as a two-step process. So there's really a screening test originally, and then after that, if you need to, you can progress to like the second step, which is the confirmation test. And I think if there's anything to kind of take home from this lecture is always talking about screening tests as presumptive positives, because there is false positives and false negatives, and you only really make that mistake once talking to a patient about, really holding your hat on the results of a screening test to then have it come back different for the confirmation. And so these are the screening tests. They're mostly, enzyme-linked immunosorbent assays. We like them because they're cheap, they're rapid, they can be automated. The issues with them are false positive and false negatives, and there's also a limited variety of tests you can do with these. So in order to develop one of these assays, there has to be enough of this substance use in the population to make it profitable. And so for your more exotic substances, there are sometimes not assays available, and you need to just send directly to confirmation testing. And the other thing to know about these tests is there's two primary ones. There's lab-based, and there's also point of care. So point of care is the cups or the tests that you can do kind of on your own, and the lab is done in a lab. And the lab has basically better sensitivity and specificity. Then the follow-up is gas chromatography and more, and increasingly more things like liquid chromatography. But the pros of this is that they're highly sensitive, highly specific, very flexible. You can test for almost anything. But the issues are you have delayed results, and they're labor intensive and they can be expensive, depending on where you work. At the VA, the results come back after about 5 or 6 days now, which used to be about 11 or 12 days. And you could think if you're trying to make a clinical decision, and it can be very difficult to wait that long. Cost is also an issue. They're about $100 to $200, depending on what you're testing for. Yes.
It's been industrialized so that you can get GC mass spec level testing done for what used to be the kind of prices you could do the enzyme test for. There's an outfit in Michigan that why is this attractive? First of all, it's actually very accurate and precise. It'll tell you which benzo, it'll tell you which opiate, but more than that, you don't have to deal with urine collection. So in a private office, you put a Q-tip in, stick it in a broth in a tube, FedEx it to wherever, and then they send you back incredibly accurate results. So it's possible, but for years it's been like $185 per test, and it's basically been done for to confirm something in a dispute, or to look for something kind of rare or hard to detect. But the world is changing. These things cost, as I remember, 10 years ago, it was costing about $10. You could build your own panels. So for example, if you're treating a physician, and this physician has got access to all kinds of wonderful medical drugs, you can build panels for those drugs. So that becomes useful when you're dealing with somebody's medical license and so on. Anyway, the world is changing.
Yeah, it's a great point, and it's especially for people in private practice who has the ability to work with these labs. There's a lot more options, and unfortunately, within settings like the VA and things like that, I wish we could get our lab to interact with those people, to say the least, because we're still kind of stuck in this system. So who here in this room has sent out GCMS confirmation tests before? Yeah. And what kind of things were you guys looking for?
I had a patient on my inpatient unit who just she came in sort of manic, looked incredibly twitchy and uncomfortable, and we were convinced that there was something she was using, and her test came back positive, and she was adamantly denying she was using anything, and the confirmatory test supported that.
Okay. So it's helpful. So it was to verify a screening test when the patient was really denying that it was happening. Yeah. Sure. Jen and Chris?
I think I've sent clonazepam before.
Gotcha. When it came back negative.
It came back negative, and I thought the person wasn't taking it.
Okay. And how did the test come back?
It came back. I think they were taking it.
Okay.
Yeah.
Gotcha. So it was helpful.
Same thing
Yeah.
with the benzos, actually.
Gotcha. Okay, excellent. All right, so one of the questions is, because we're all interested in, conserving medical resources, and this is there's some people do this differently. Some people just kind of reflex confirmation test everything, but at least in my clinic, where there's incredibly high rates of positives for lots of things throughout the year, that's really, and we know somebody has been cocaine positive for the last 5 years. I think an argument could be made that that's pretty wasteful of medical resources to continue sending confirmations on all these. So one thing I like to really think through very clearly is when to send a confirmation or not. So one is, this one I hopefully is pretty straightforward. If a patient is positive for amphetamines, is always positive for amphetamines, and says I smoke meth, would you need to send that? No. Okay. Let's say somebody is urine drug screen is negative for buprenorphine and is prescribed buprenorphine through office-based setting and says that they are taking their buprenorphine. Would you send that? Excellent. Okay, and then how about this one? Urine drug screen is negative for amphetamines and is being prescribed methylphenidate for ADHD and says they're taking it. Would you guys send that out for confirmation? Okay, I see yeses and nos. Let's go with a no.
Because Ritalin doesn't show up as amphetamine.
Excellent. Yes. So this is kind of a trick question. So methylphenidate is different enough, is a stimulant, but it's different enough from the amphetamine structure that it doesn't actually interact with those assays. And so you actually have to send out specific tests for methylphenidate if you want to monitor that. Okay. All right. So this is just some information about how to send out a confirmation test here at the VA if you need to. And it essentially is a multi-step process. You need to put in, the assay, the immunoassay needs to be read. You need to catch it within a couple days. And then you also have to then place this miscellaneous lab order saying what you want to do. And then you call the lab. And then even after you do all of these things, maybe 70 to 80% of the time does it actually get sent out. So that's the other side of reflex testing. Is if you just reflexed it, a lot of these would probably end up going out more regularly. But this is the downside of not
Is that
reflexing.
because they destroy the sample after 2 days?
That's because they lose it. That's because they decide they have to call the lab medicine resident who never necessarily gets back in touch with them. That's because of all sorts of things. Yeah. Okay. All right. So this is another slide. So everybody kind of wants to know if my patient used X drug at this time, how long will it be around so that I can detect in a urine test? And this basically that question is incredibly complex and based on all of these factors, probably plus a lot more. So it's very hard to say, and there's a lot of individual variability between people. Like I have patients who I know pretty well who smoke cocaine, and they'll test positive for like 7 to 10 days afterwards, and then other people who clear in like 3 days. So it is variable. But with those caveats, this is a general slide looking at detection windows for different things. And these slides are all available to you guys, and most of these slides I recommend just using as reference slides. Like you can't remember all of these things, but just having them available is helpful. What we're seeing, and kind of what Peter alluded to, is that urine has been the mainstay for a long time in testing, and it's still what's being used in like Department of Transportation and other things like that. But oral fluid testing is becoming increasingly inexpensive. The technology is getting much better, and I think most people say that probably in 5 to 10 years, oral fluid will replace urine testing for clinical drug testing. And that's mostly because you don't have to deal with urine, you don't have to deal with all the kind of adulteration stuff that goes along with it. The one thing you do get is a slightly shorter detection window compared to urine.
Are you going to talk about adulteration?
Yes, yeah, I got that in a few slides. Yeah. Other things that you should know is things like hair samples, nail samples can have detection windows for up to 3 months and can be used in certain situations when you're looking for a longer window of detection. And so the other thing is really thinking through clearly, like what's the clinical question I'm trying to answer, and then being thoughtful about what type of sample you get to answer that question.
We only do urine here, the lab.
We only do urine, yeah. So hair and nails, I don't know, can you guys do that at general? No. Yeah.
Oh,
So
no.
hair and nails is more like private practice or, private rehabs and things like that. But it's important to kind of know about that. So this slide, again, you don't have to memorize it. This just shows different cutoff levels for the different assays that are recommended. So some things that are important to know about this is if somebody tests negative for a substance, that doesn't necessarily mean that there's actually none of that substance in their urine, and we need to be mindful of that. What it means is there was not enough of this substance present to be above the threshold we set to list as a positive. And this can come into play sometimes. So like for instance, I had a patient who was in my methadone clinic taking oxycodone at the window, and we were like watching him, making sure he wasn't cheeking it, and he still tested negative for oxycodone. And so we actually called the lab and said, we actually don't want just the yes or no, positive or negative. We want you to give us the number. Like, what's the number? And at least for that, like the cutoff was like 500 and the number was like 496. So that was incredibly helpful to have that information. And you can actually call the lab and ask for that. I want a number, not positive or negative. And that can be very useful in clinical situations.
You can follow that too. Like we would do that in our adolescent substance use clinic at Children's.
Yeah, excellent. Like, so following levels over time, especially for cannabis or things that take a long time to clear out, is a thing that people do. And I'll say that these cutoff levels have been mostly adjusted up over the last decade or two, because the goal is really to set a cutoff level where you minimize false positives and be willing to have some false negatives, essentially, is what people are trying to do. Okay, so this speaks to a little bit about adulteration. these are tests, at least for urine, that we call validity testing. And so we have at the VA, I think it's called like the OTP tox screen set. And what that does is it gives our usual drug screen, plus it automatically adds on these validity tests. So urine creatinine, specific gravity, and pH. And what those essentially do is, especially if you're doing a lot of unmonitored or unobserved urines, you can check to basically see is this sample consistent with physiologic human urine. And so the things that you look at is kind of, is it within the pH? Does it have the right amount of creatinine? Does it have the right specific gravity? And the other thing that we monitor too is, which we just bought because a program in Chicago told us you could just buy these infrared temperature guns off Amazon for like $10. And so we just use that to make sure it's also the right temperature if we have a concern. And that gets around things. People will do all sorts of things with tests, like give things that aren't urine, microwave things, add things to the test, usually nitrates, to try to get around it. They do all sorts of things. And so this is...
They give their babies, they submit their baby's urine.
Mm-hmm. Yeah.
Or get a friend. We've had patients who've gotten another patient to provide the urine, and then we pop them for drugs in the other patient's urine.
Yeah.
The wrong patient
Yeah.
gets blamed for the
So, so be careful where you get the urine.
I've got it, I can dig it out for you. There's a very big review article of beating the drug test. And after you read it, this is adulteration, adding things, substituting things, all kinds of stuff. It turns out that the stuff that's on the internet is actually pretty accurate about how to beat a test. And it's not what I hope to read as a final conclusion, but a lot of these methods are really, really very effective.
Yeah. And I'd say, and to add to that, I think if you really want to, if you're willing to do anything and you really want to beat this test, like the test you can. So for instance, in my fellowship, we had a patient who was medically savvy enough that he actually catheterized himself and emptied out all his urine, and then took somebody else's urine and injected it into his bladder, and then gave that as a sample and passed the test. And the only reason we actually knew about that was that he was so proud of what he did that he actually, in a few weeks, told us about what was going on. And
true story.
So, yeah.
In the Los Angeles Olympics, the drug people were UCLA people, and they were hot on the trail of a Bulgarian weightlifter who they knew was doping. They just were sure of it, and they couldn't catch him. He was always clean. And one day on a lark, after another negative test, the guy running the lab says, put it under a microscope. And they looked at the urine under a microscope, and it had vaginal epithelial cells. And that's exactly what he had done. He put his girlfriend's urine into his bladder. They've been doing it for forever.
Yeah. Okay, so these validity tests can be useful, and especially like if you're doing unobserved urines. If you're doing observed urines, you can still do them, but it may also be kind of a waste of extra testing and resources. So we're often only sending those, at least in my clinic, when somebody's getting unobserved urines. This is a slide for reference that lists some of the more common false positives in the different assays. I mean, the ones that I've come across, like our bupropion for amphetamines and sertraline for benzodiazepines. And the thing that is actually interesting about these, that I've talked to like head MROs, toxicologists, that I've never been able to get a straight answer for, is sometimes you can get these false positives and you send the confirmation, there's no benzodiazepine, there's no amphetamines, we really think it's the medication. But it doesn't do it every time. Sometimes it's positive, sometimes it's negative, and I've never been able to get a great answer from people why that is, except for, variable metabolism or maybe not perfect adherence to your meds. But just something that clinically you'll see. So if somebody's on sertraline, they have a false positive for benzos, you think it's the sertraline, don't then go with the expectation that every time you test them it's going to be benzo positive, because it does vary, and it's kind of an odd thing.
Over the decades, the false positive issue for me has been mostly the stimulants. The rest, immunoassay usually gets it right, but the stimulants, occasionally, they don't get it right.
Yeah, the amphetamine assay is problematic. So that's a good segue to the next question. So we think about these tests as like, oh, we sent a drug test as a single test that has these 8 different results. But actually, the way you should be thinking about it is each of these tests is a different test. They're just been combined. And they all have their own sensitivities and specificities. So specifically, cocaine is really the best assay we have. It's highly sensitive, highly specific. It's so sensitive and specific that we almost never send out confirmation tests for cocaine because it's actually a waste of money. I think the positive predictive value is about 95%, and I've never sent one and had it come back discordant with the original test. Now, we still sometimes send them if there's going to be a big clinical treatment decision or something around it, but it's almost never different. Cocaine is also variable. We have a very sensitive assay at our lab, and the other point for you guys to know is like different labs use different assays, and so it's important to get to know your lab and the intricacies of that lab. And so, for instance, cocaine for some of my patients to hang around for 7 to 10 days at our lab, which is very rare in other settings. Cocaine is usually 1, 3, 5 days, and up to 5 days in other settings. Cannabis, as you mentioned earlier, Martha, can hang around for up to 6 weeks, especially in heavy regular users. If you use cannabis once, it usually hangs around for a couple days, if at all. But regular, daily, heavy use can hang around up to 6 weeks. And you already answered what my question was going to be here. So you can monitor the levels over time, because what can happen is people can get into clinics, into residential treatment centers, say, I'm not smoking anymore, and they know that it's going to take 6 weeks to clear out, and then continue doing so. And so some people, if you're trying to create an environment that is kind of abstinence-based, because other people in recovery and don't want to be triggered by their substance use, they will sometimes monitor these levels for this and other substances to make sure people aren't using in that environment. Okay. And what you also often should do for these is do creatinine corrected levels. So because the concentration of your urine varies throughout the day, so the best time if you're trying to detect substance use is to get the first urine in the morning because it's the most concentrated. But creatinine levels in urine vary over the day, and so will the levels of the drug. And so they will often do creatinine corrections in these, especially if you're looking at levels over time to make sure you're getting an accurate trend, either down, up, or stable. And you can just ask the labs to do that. It's like they're very familiar with that. Okay, so as Peter was mentioning, the amphetamine assay is very problematic. There's lots of false positives. One thing to know is that methamphetamine is not a metabolite of other illicitly used stimulants. So if you see that in a confirmation panel, that means people are using meth. There's a weight loss drug they love to use at the VA that always tests positive for amphetamines. I'm just wondering if you guys know what that is. Yeah. I don't know if they use it in general, but. Phentermine, yes. So lots of people are on phentermine, and it will test positive for amphetamines and something. And so phentermine is one part of the old fen weight loss drug that actually got pulled away, I think because of arrhythmias or cardiac issues. So they kept one half of the fen, and they're still using that. And something you should know about. The other thing that's interesting is that I don't think it's around as much, but you can still sometimes get it. Some of these Vicks inhalers actually have L-methamphetamine in them. And if you guys remember back to organic chemistry, you have different enantiomers, and the L-methamphetamine molecule is actually a very good decongestant, but there's no real rewarding properties. The D-methamphetamine, or the D as in drug, methamphetamine is the one that makes you feel high. So people kind of know that, and so you can actually do chirality testing on these tests to determine whether there's a D or an L enantiomer present, and so knowing what people are using. But as we talked about, people are also very savvy at these testing, and so what they were having issues with was that people were using D-methamphetamine and then also snorting huge amounts of Vicks to try to overpower the ratio to where it was mostly L-methamphetamine. Luckily, the L-methamphetamine is out of most of the Vicks inhalers at this point, but you can still find it sometime, and it's something to know about. Okay. All right, so let's talk about opiates, because probably of the assays, they're the one that's most complicated to interpret. So how about just rapid fire, the actual opiate test, what opioids test positive for that test?
Morphine, oxycodone, OxyContin, Dilaudid. Is that what you're looking for?
Yeah, excellent. So just so everybody heard, morphine, oxycodone sometimes, like because we have a special oxycodone test separate because it doesn't always. Hydromorphone does pretty well. How about some other ones? Heroin, yeah, because it's just diacetylmorphine, right? So it'll do that. What else?
Codeine.
Codeine, excellent. What else? There's one more that we love to prescribe in America. And we had to reschedule it because we love to prescribe it so much.
Hydrocodone?
Hydrocodone, there you go. Yeah. No, and
Dennis' favorite drug.
yeah. Tramadol does not test positive on opiates or in any of these tests, and you would actually need a specific test for that. Okay, so those are the ones. Hydrocodone pretty consistently. Oxycodone for most people only at higher doses because it's a semi-synthetic opioid, and that's why we have all these kind of separate tests. So oxycodone will test positive for oxycodone and oxymorphone on that test. Methadone will test positive for methadone and EDDP, which is the primary metabolite of methadone. Buprenorphine, we test for buprenorphine, norbuprenorphine. Now, why do we test for methadone and buprenorphine particularly? Why are we interested that both the parent product, like buprenorphine and norbuprenorphine, are in the sample? Why are we interested in making sure the metabolite is in the sample? And I think, Chris, you already have heard these lectures, so it's somebody else. Yeah.
Actually taking their medication and not just, I don't know, putting something in urine. You want to make sure that they're metabolizing it.
Excellent. Yeah. So what people will do, especially if you don't observe them, is you can take your Suboxone tablet and shave off a piece and just put it directly in the cup. And then what will be positive will be full buprenorphine with none of the metabolites. There'll also be a huge amount of naloxone in there too, so you can also check for that as well to know that it's been not an accurate sample. But yeah, that's why we're interested in it. Here's 6-monoacetylmorphine, which we talked about, and then poppy seeds. Typically, if it is poppy seeds, what you'll see is very low levels of codeine and morphine present, and there's a ratio that is usually most of them are higher codeine, less morphine for the poppy seeds, but it also varies like depending on where the poppy seeds are from, like Turkey versus wherever. So it's not, but it's something to know. You should expect to see both if it's poppy seeds, and they should be low levels. Okay, here's another reference slide. This is just opioid metabolism. So what will happen when you guys start to send confirmation tests, which is a standard part of clinical drug testing I encourage you to do when it's necessary, you'll get a panel back of 5, 6, 8, 10 opioids. And what you'll need to kind of figure out through opioid metabolism is, what is my patient prescribed? What are the different opioids that are present in the sample, and how do I make sense of this? And so the best way to do that is to just have these kind of reference slides to kind of figure out. And usually when you have these slides, you can figure out pretty quickly kind of what's going on. Okay. And there's a similar thing for benzodiazepines. So we talked about clonazepam not working with benzodiazepines. One thing that's important to know at least our lab, something like Librium at our lab, like we give Librium 3-day outpatient alcohol detoxes all the time here, and that will hang around for an incredibly long time. I've seen it positive for up to 6 weeks for people. So just being mindful of that is important, because during that time, at least on a screen, you can't tell if people are taking other benzodiazepines, continuing to. And also, patients can also get in trouble at residential treatment centers and other things like that, because it's 5 weeks later and you're still testing positive for benzos, and they can potentially lose their spot. So you have to do some education around that. And because of that reason, that's one reason that we thoughtfully really decide what benzo we want to use in certain situations. And so we often use clonazepam sometimes specifically because of that, because we don't want it to show up on their urine, so that we can monitor more clearly later if they're using other benzodiazepines. That's that. And then here's another slide that shows more in-depth benzodiazepine and opiate metabolism that you guys can use as a reference. Okay, so alcohol testing. We talked about this a little bit earlier, but just things that are important for you guys to know is...
Sorry, could I just ask about the last...
Yeah.
if the assay is based on value diazepam,
Mhm.
why is it sometimes positive for the other three at the bottom?
So, yeah, so the benzos all have a similar structure, and what I was told is when they developed the immunoassay, the benzos that were around most of the time were librium and diazepam. So they made the antibodies to match those. And I don't know if I'm answering your question, but I'll just finish, then you can tell me if I didn't. And so then all these other benzodiazepines are close enough in structure that they still bind to that antibody, but only, depending on how different they are, the percentage of binding and how good they are varies.
And how high the dose is too.
Exactly. Yeah.
Okay.
Yes. Yeah. Okay. So alcohol testing, just some things, basic things on that. Most people clear 1 drink per hour for their liver, or 0.015 when you think about breathalyzers and things like that. So you can use that, but it can be really variable. People who drink a lot can clear a lot faster. So this can be useful when you're in the ER or other places to calculate this person is here and their BAL is 0.3, and when will they potentially be below 0.08? When will they potentially be at a place where I can conduct a psychiatric interview with them that has some value? Things like that is helpful to know. We talked about ETG, ETS. There's also more non-specific tests that you can get on standard liver panels. AST, ALT will show inflammation, at least in early stage drinkers. That can be helpful, but it's non-specific. Other things can cause it. MCV is more often late stage drinkers, and when you see a MCV above 100, that can be suggestive of chronic alcoholism. And GGT is also something that's pretty quick, inexpensive, and is most useful for monitoring over time. It's very non-specific, but if somebody's drinking a lot and then you check it and you have that level and then they say, really, I cut down or I haven't been drinking, and then you check it a month or two later and that's gone up, that's not usually consistent, right? So you can identify general trends with GGT in a very cheap and efficient manner. And it can be useful as far as that, monitoring over time. Okay. So we talked a little bit earlier about drug use in the workplace when I showed that data, so I'm not going to really jump into that, but that's there's a lot of concern about drug use in the workplace, especially in safety sensitive positions. And so that created a field in medicine called the medical review officer. And how many people have heard about medical review officers? Yeah, that's true. Are either of you guys MROs?
Yeah, I
Yeah.
was.
Yeah.
I had no choice.
Okay, yeah. So that's a good thing. So at the VA, I don't know if you did it here for a while, but
No, I did it here.
Yeah.
I tried not to do it, but I couldn't get away with it.
Yeah. So then Peter was the MRO here, and then my predecessor David Kahn was the MRO, and then I did the training just because I was interested in it, and then I was supposed to be the next MRO, but then Steve Botke got me out of it, which was very nice. Because there is kind of a conflict of interest. I would be looking at urine drug screens for Q or for my colleagues, and people way above my pay grade, and so that's maybe not ideal. And so they were supposed to find somebody outside the VA to do it, but what they essentially did was just make one of the lab medicine people do it. So, but
there is a benefit to have an MRO looking at things, because you don't have the drug test determining some kind of crime or pathology. And what the MRO does is you get a positive for something, you contact the person and you say, are you on prescriptions? Are you, what are you doing? And in many cases, what's being picked up is a prescription. And the MRO has the right to simply negate that, and they get a clean result.
Excellent. Yeah, so the MRO's job is to basically preserve the integrity of the drug testing process. So results come to them first before they go to employers, and you kind of talk to the patient and determine whether this is a medication that's prescribed or whether this is something else. And then based upon your kind of expertise in interpreting these tests, you then decide what actual result gets reported. And so it's meant to help, especially in safety-sensitive positions, protect the public, but also to protect people from being, falsely accused and stigmatized and things like that.
There's another issue. It's not an MRO issue. It's when you get a sky-high breathalyzer reading on a patient who's driving. What do you do? Way over the legal limit for drunk driving. And you just got it as an incidental pickup because you smelled alcohol in a group.
Is that a question? Clinical question?
Yeah.
Yeah.
It's a complicated
Yeah.
question.
Sure. Yeah. The first thing I would do would recheck it in 15 minutes to see if they drank right before coming into the group. But then after that, it gets more complicated. Okay, so wrapping up with some general principles, I think we touched about some of these, but I really want to say first thing is really using these testing. They can be incredibly supportive for patients, and as long as you're not using them in kind of a punitive manner, I think they're really clinically helpful. The deterrence rate, which is quite large for drug testing, is almost entirely based upon randomization. If people know what they're being tested for, when they're being tested for, whatever, it loses that deterrence rate. So in a perfect world, or if I had a private practice where I could do this, I would randomize not only the dates they're tested, the frequency at which they're tested, which panel they're going to receive, so they don't know what actual drug tests are going to be on the panel, so that rotates. And also, one day it's oral fluid, the next day it's urine, the next day it's hair. And if you do those things, or as close as you can to those things, you achieve like the highest deterrence rate, essentially.
And if you're a doctor or a nurse who's being monitored by the state board, you have 4 hours. The computer pings and says test time. You have 4 hours to produce a sample. If they don't, it's considered a positive.
Yeah. Also think through very clearly what matrix you want to use. So, the different samples are here, but thinking about what the question you have is, what detection window you're looking for, and choosing based on that if you have those options. The thing that people don't do, which we really need to do, is update our test panels. So drug use changes over years, if not decades, and people, for a while at the VA, we were still testing for barbiturates and PCP and sending thousands of tests per year that were never positive, right? So what we did was we took away the barbiturates and the PCP and kind of the regular tests and said, okay, well, we took away all these. Will you now please give us fentanyl as a test? Because that actually is relevant. And unfortunately, that did not work. They took away the test, but it wouldn't give us fentanyl. So
barbiturates is still on the test.
What's that?
Isn't barbiturates still on it?
It depends on which one you
I
use.
see.
Yeah,
Which one I choose
yeah,
on
yeah,
them.
exactly.
Okay.
You can still get it, but it was like it was taken off standard
Got
on
it.
some of them, so you actually have to really want to ask for it. Yeah. So the other thing is to think about observed versus unobserved testing. So there's good data that shows you only have to observe about 25% or so of urine drug samples to have a similar deterrence rate as if you're observing them all. So we try to do that, keep to that in our clinic, randomly having our nurses observe about that amount, because nobody likes to be observed, and frankly, the staff, nobody likes to observe people. It's like the worst job ever. So you want to try to minimize that for everybody's sake.
If you're curious about one way of getting around being observed, look up Wizinator on the internet.
Yes. Yeah. So other things is thinking about, I guess what I'm trying to say for rapid feedback is it's helpful to have point of care in certain situations. So the most important is contingency management. So the whole effect size of contingency management is matching the behavior or the test to the reinforcer. And what do you think we do when we have the urine go off to the lab and we wait a few hours and then it finally comes back and the patient went to lunch but maybe they didn't make it back? We are really minimizing that effect size. And so if you can have point of care, that's by far the gold standard for contingency management. And there's also certain situations where I have patients who are in bad withdrawal from opioids. We need to do a bup induction, we need to do a Vivitrol induction, and we can't wait sometimes hours for the lab test to get us back. So point of care is also useful for those things. If you run a clinic to where you're getting a lot of invalid samples on those validity tests, that might, I would have you consider that might suggest to you that you're doing your testing in a punitive manner, and that your patients are feeling the need to try to avert these tests and get around them and things like that. And so you might want to think about how you're running your drug testing protocol. And then the other thing that I think is really important to think about is the frequency of what you test. So this is the idea that if you looked at my life, anybody's life under a microscope 24 hours a day, you would see things that you probably are not good, right? So let's not hold our patients to a higher standard than we do ourselves. And if you test somebody every day, you can end up finding things and that are not actually kind of useful in them improving their life and things like that. So being very careful about what is the goal of the monitoring and what and how often to test for that.
Harm reduction approach that you don't tend to see in America so much, but you see it in Australia and Europe, where they've decided to do very little testing at all, on the notion that it makes people feel safer, that it's not going to somehow, get given to law enforcement, and that in the end, what they say is, I don't need a test to know that patients won't tell the truth and that they will have lapses and relapses. I don't need testing to tell me that. And they try to build a culture where the patient is revealing more freely, because it's clearly not a punitive environment. So it's a question of taking the punitive overtone out if you can, and sometimes you can't in a legal case or something. But some of my Australian colleagues argue very forcefully that it's a waste of money to keep doing all this testing, and that in the end, they stay in clinic because they want to get better, and eventually they start telling more and more the truth.
Okay, and that is the end of the lecture. Here are my references, and do you guys have any questions? Yes.
What about synthetic cannabis? Is that like K2 spice or those on? Is that a special send out test?
So there are assays available. At the VA, we don't have that assay. So depending on your setting, there are some screening assays you can get. But for us, it's a send out, and we can get it. But yeah, and they usually will have a synthetic cannabinoid panel, and it sometimes has a handful of different synthetic cannabinoids, like the most common ones.
Okay.
But if they do, there's a lot of exotic synthetic cannabinoids you can find that aren't going to be on any panels. And that's what some people, if they're really savvy and they're on like blue light and Arrowhead, that's what they'll find. Yeah. Any other questions?
Test for kratom?
Yes. So you can test for kratom. I think they've developed an assay for it, but we, again, at the VA, it's a send out for us, but we do, and we see lots of kratom use. And primarily, my patients are finding kratom information on YouTube and online and using it, and primarily trying to use it as ways to either wean themselves off of heroin or even to wean themselves off of Suboxone often, and we've seen variable success with that. I've seen people that it's actually worked quite well for, and I've seen people who it hasn't, and then they get stuck on kratom and they're having a hard time with that, so yeah, but that's something we should all definitely be talking to our patients about, because it's very present. Yeah. All right, thanks for your attention.